In terms of what's coming up in the mini masterclass series in 2023, first of all in January we have Katie Biggs, who's going to be talking about making trials more inclusive. I think we're expecting big numbers for that one because obviously inclusivity in health research is a huge kind of hot topic at the moment. So join us for that if you can. And then after that in February we have Professor Steve Goodacre. Steve has worked in ScHARR I think pretty much since the beginning. I've been in ScHARR nearly 20 years and he was well established here long before I came. He's going to be talking about clinical risk prediction. What are we predicting and why? So that's a really big deal to get Steve to come along and do one of these. He's a very busy guy. So that's what's coming up in February. But today we have Dr. John Richmond, who's here to talk about health system emergency preparedness from COVID-19 to climate change. Now, I remember John, I don't know whether you remember meeting me, but John started at ScHARR in March 2020, which for those of you that are based in the UK, you may remember was the month that we all went into lockdown. And I'm pretty sure, John, your first day at ScHARR was also your last day in the building, because I'm pretty sure I remember saying hi to you. Catherine Grinold was giving you a tour of the building and I remember thinking, oh no, he's starting today and it looks like we're going to be told to work from home any minute now.
That's right.
Yeah, I know. I remember thinking this is awful to start a job and then be immediately going into a lockdown. But anyway, yeah, John has worked with us since March 2020. Prior to that, he did a PhD at Warwick Business School and then postdoctoral research, and he also has a decade of experience in the healthcare industry. But with that, John, I will load up your slides. Just give me a moment and then I'll hand over to you. Hold on. Okay, over to you, John.
Thank you so much, Claire. So I will dive right in. So our topic today is health system emergency preparedness, and we will be using some examples and context from both COVID-19 and climate change. So already had the excellent introduction from Claire, but just to reiterate, I am the program director and lecturer in healthcare management and leadership. I am also responsible as the research theme lead for health and the environment here at Sheffield. My academic qualifications are a PhD in management and my postdoctoral fellowship as well, both from Warwick Business School here in the UK. And really this builds on 10 years of practical health management experience that I have in a couple of different countries, and perhaps most relevant of that experience was I used to be a hospital risk manager and dealt with a number of disaster management and emergency management type situations in Eastern Canada. And building on all of that, and our focus today is how healthcare organizations prepare for and respond to emergencies. And this is a high-level presentation that I hope sparks some interest and gives you some insight into my area of research and how we can move this field ahead. I'd like to give us a brief overview of the challenges facing health organizations today, and also talk a bit about how do organizations actually develop preparedness. And in order to do that, we need to define some key, what I would describe as fundamental emergency management terminology and activities. And we're going to look at specific examples from the COVID-19 pandemic and lessons learned. And I also want to focus upon extreme heat events, which are increasingly common and induced by a changing climate. We will also talk about some future research and next steps, and also take some questions. So the challenges to health organization and to a modern health organization are that really disasters are becoming more commonplace. The intensity of them, the frequency, severity, and their cost is rising. It's not uncommon for disasters now to go on for a prolonged amount of time. We think about COVID-19, it's been going on for several years. You know, now the pandemic is basically at an end, but What this does is it means we have to be prepared for managing concurrent disasters simultaneously. And there's a lack of really planning at a health facility level for the effects of climate change and the consequences on healthcare delivery. We know that healthcare costs are rising and systems are strained. There are big problems with staffing, for example, nurses here in the English NHS and as well in the Canadian healthcare system. So emergency management systems in health are largely underdeveloped, uncoordinated, and underutilized that we'll talk about today. The health system will only continue to be challenged as time goes on, and requests for support and resources will really only intensify. Over on the right-hand side here, we see a picture from the Canadian province of British Columbia and how they are impacted by wildfires. And we'll actually talk a bit about British Columbia today. So I want to define some key terminology so that I can help you get a better sense of really what we're talking about. And I think the term preparedness, it gets bandied around a lot in both the popular media as well as I find academically as people come to this field. But really what I'm talking about and how preparedness is defined is it's the ability of a health organization to stay operational when the demand for your services outstrips supply. So we think of a disaster-affected population like a mass casualty event. Think of Manchester, the Manchester Arena bombing, for example. Preparedness in that sense was, maintaining our operations when we had this large influx of critically injured patients. So it's about how do we develop that capacity to enable us to respond when demand on us is high. That's really what preparedness means at its most simple form. And it's a definition I'd like to carry forward here throughout the rest of the presentation. I think if you have any exposure to this field, you've seen this before. But what this tells us is that emergency management is a process. It's a cyclical process where we find ourselves preparing for emergencies, and then in a sort of discrete fashion, we are then responding to emergencies. So, it could be, forest fires, for example. But typically we think of emergencies as sort of having a beginning and an end. And when the response ends, so when our frontline responders, whether that's ambulance, fire service, police, whatever it is, when their response ends, then we tend to enter into a phase known as recovery, which is where we do our after-action reviews, which is when we start to do planning. We think about how we can improve for future disasters. If we're lucky, we'll get to something called mitigation, which is where we can actually enact some learning from that recovery process, from those after-action reviews, and put mitigating techniques in place. But I think the key takeaway here is that, being prepared and enacting emergency management, it's actually kind of a temporary way of managing your organization. And I'll tell you a bit more what I mean about that in the next couple slides. So in terms of healthcare, there is a growing recognition of the need to actually employ a dedicated professional. And what I mean by that is, you might think, oh, okay, well, nurses in the emergency department, they should be good at emergencies, right? Well, this takes it a level higher than that. We actually need a skilled manager or someone who is a skilled, like a director, for example, in the organization, who actually owns that portfolio and can ensure disaster preparedness across a wide variety of disciplines. Some countries, like in Canada, we have a health emergency preparedness framework. Yet I find these frameworks tend to be very much at a public health level. For example, learning from the ScHARRs, from the ScHARRs infectious disease in Canada. This is something that fell out of that, but it tends to miss the more operational level concerns at a healthcare facility type of focus. So when I talked about temporary organizing, What I mean is that everybody knows what an organizational structure looks like with a CEO at the top. Except when there's an emergency, we activate something known as an incident management system. The most popular of which in healthcare is HEICS, HEICS. And the purpose of this is it allows us to manage the response effectively. It's usually physically embodied through something known as an emergency operations center, which is where the action happens. That's the heartbeat of the emergency response. And in there, every person assigned to that, they may already be, a vice president or a medical director or a nursing chief nurse, whatever their daytime job is. Now they've essentially been given a position in this new hierarchy, and they all have roles, logistics, planning, communications, dealing with the community, but most importantly this is led by an incident commander, and this is typically sometimes it's the CEO of the hospital, but it is not always, and we'll talk more about that. In Great Britain, this system goes more by the title of gold, silver, and bronze. So that might be more familiar to some of you, and that's what we would call the strategic, tactical, and operational command structure. So that's the UK language. I want to dive in a bit to actually how health systems responded to the COVID-19 pandemic. And we're going to do that using the context of Canada as one example, which is my home country. But when I was working at Sheffield in 2020, I actually led a study that I will describe here. But before I talk about the study, you need to understand that there is about 40 million people in Canada. So it has a smaller population than the United Kingdom, but a much larger landmass. And we also have 13 provinces as well as territories. And yes, we do have socialized medicine to a degree. The federal government funds the overall health system, but each of these 13 provinces and territories, they have their own individual health system. And they are left to determine how to best configure their services. This does present a challenge when we're talking about national emergency response. We're talking about interoperability and the ability of provinces to communicate with one another. Ontario alone has more than 200 healthcare organizations, as an example. So let me tell you what we found. So in Canada, most hospitals do employ an emergency manager. This person builds comprehensive programs based on key preparedness activities. But the prevalence of these activities and whether they're effective is not known. And in fact, in Canada, we have something called Accreditation Canada Requirements, which is really a nice to have. It's a badge of quality for your hospital to obtain, not unlike the CQC ratings here in the United Kingdom. But how is it operationalized? How are those requirements for emergency response actually operationalized? So we set out to, this is the name of the study, and the citation is at the bottom. This is a study that I led during COVID, and we wanted to look at how disaster preparedness activities form part of a comprehensive emergency management program in healthcare. And perhaps the most important is, what are the conditions, the moderating conditions, which either enhance or detract from the preparedness of a hospital? And so we actually were able to survey 150 hospitals, complete responses, including representation from all Canadian provinces. As well, we did 20 in-depth interviews with leaders in this area. So I just want to spend a bit of time here because these are what we learned when we did our literature review was that there really was no way to, there was no validated tool to assess whether a hospital is prepared. So we did the research, and this, you can see our citations at the bottom, around assembling what we felt were the key activities that hospitals should be doing to develop preparedness. And so specifically in the context of COVID-19, we wanted to look at pandemic plans because we know that there was increased awareness brought about by the SARS outbreak, for example, in Canada. And so these infectious disease plans, though, we didn't know how effective they would be for something, because they were too specific to influenza. We want to know, do people know what the plan is? How up to date is it? And how embedded is it in the organization? Next, we wanted to look at, obviously, PPE. Everybody knows about personal protective equipment and whether staff were trained in that. Tabletop and simulated exercise. This is really important for building preparedness. It means, do people actually have the competency? Have they ever actually been trained in how they should respond in an emergency? And there's a lot of great research done about, that people do feel, like perceptions that people give of health professionals, that they do feel more and better prepared to respond having gone through simulations and exercises. The difference between simulation and tabletop is that simulation actually means bringing all the actors together, running a day-long or half a day training session in a hospital, in a boardroom, and creating your emergency operations center, running through their roles. Following on from that, we wanted to say, well, what about activating your emergency manager incident management system? Do people know what their roles are? How often do you do that? Further, and really important, is multi-agency response. When you're in an emergency situation, you need to draw from your community, and that might include, the city, the local authorities, fire, police, community, long-term care. So have you actually trained for that multi-agency response? Physical emergency operations center. Because COVID was so prolonged, a lot of hospitals actually set up kind of a semi-permanent area, and that was the emergency operations center, where there was daily updates given, a boardroom for holding meetings, but of course, because of the pandemic, in many cases, this moved to a virtual setting. And we also looked at clinical management strategies, not to leave medics out in the cold here. We wanted to know about things like surge capacity development. So how do they bolster the workforce when the hospital is affected? And perhaps to summarize this, we developed kind of a preparedness score, using some composite scales. And really importantly, we looked at the training score. And what we meant by that was, did your incident commander, your leader, did they receive any training in how to respond effectively to an emergency? And the results are quite interesting. So let's just quickly look. This is the demographics from across the 150 hospitals that we looked at. And what we found is that actually the person that was designated as an emergency manager, so let's say 40% of them, it was kind of their sole or primary responsibility. So they were truly an emergency manager. That was their job title. However, in 39% of cases, it was a secondary role. So it might be a binder of, fire codes or evacuation plans that sits on a nurse manager's desk or a clinical director's desk, for example. And perhaps most interestingly here is that during the COVID pandemic, 21% of people who described themselves as emergency managers, that was emergent. They were deputized during the emergency itself to get into the game and to become part of the emergency response. Now, when we think about who actually leads emergency responses in hospitals, that's what this bottom this bottom of the table is looking at. And what this told us is that in 38% of hospitals, the emergency response was led by a sole executive, in many cases the CEO. And then secondary to that would be a sole medical leader, often like the chief medical officer. And we also found that in 39% of cases, the response was led by a multi-led team, so many different individuals. Now, what's interesting here, this is really just the descriptive statistics. And you have to remember, we rated effectiveness on a scale from 1 to 5. And it was based on the perceptions of survey respondents. So, there is limitations to this. But on average, we found that hospitals enacted 5 out of these 9 areas of preparedness. And pandemic planning was found to be the most prevalent. So 82% of hospitals had some form of pandemic planning in place. but it was actually rated the least effective activity. And we felt that that was because pandemic plans were likely more influenza specific, or they were outdated. More than half of the plans hadn't been touched since 2018. And there was a lack of overall awareness in the organization of what the plan even meant. Now, another finding here is that simulation-based exercises were only prevalent in about 26% of hospitals that we found. That's simulations preparing for disasters. But what's interesting is that this was actually rated to be highly effective, but also had a strong correlation with other preparedness activities. And that was training for multi-agency response and activating your incident management system. So simulation was deemed to be important. Donning and doffing PPE, perhaps unsurprisingly, was ranked as the most effective. And if I would just draw your eyes to the bottom of this screen where we see the composite scores for training, this is a score between 0 and 1. And so what this tells us is that 68% of leaders, emergency management leaders or incident commanders, receive training. So that means that more than a quarter of people leading emergency responses in hospitals had no training at all in how to run an emergency response, which tells us that there's a huge deficit, there's a huge gap about what health leaders know about emergencies and how to respond to them. Some of the, so doing multivariable regression, we determined a couple of moderating conditions. And so we said preparedness is positively associated with commanders who receive training, to put it simply, having a dedicated emergency manager, and having academic affiliation. The effectiveness of activities increased with having only a sole incident commander, and this is what's known as having unified command. So there is, having unified command is that you could have multiple incident commanders in a rotating fashion, which was common during COVID. But we know when there's a single leader, overall decisiveness is improved and decisions can be made more rapidly. As well, the more preparedness activities you're doing, the more well off the organization is in terms of overall preparedness. And we found simulation was the most important activity. Switching the context a bit here to the United Kingdom, we need to think about how health emergency response is ordered here. Well, you have something called local resilience forums. These are at the local authority level, and they are formed based on police areas. Now, that doesn't always correlate well to your NHS geographical areas, but I will say that each NHS organization has a seat at the table of these LRFs, and that individual who sits there is known as an emergency preparedness, resilience, and response, either director or manager. So the short term in England is EPRR. And these are really interesting partnerships who train, they run exercises, they develop, they link partners together during an emergency, and they run using this gold, silver, bronze incident management. But I won't get into the deficits yet, but LRFs are not really, they're not accountable, they're not funded, and they're not actually related. They are legislated through the Civil Contingencies Act. And this can sometimes lead to disruptions in decision-making, as well as poor situational awareness and sometimes issues of overlapping authority. Now, so as I mentioned, NHS organizations do participate in LRF to enhance their emergency response, but the overall success of them during COVID-19 was actually quite mixed. And so I would draw on the excellent work that Professor Rowena Hill has done. You see my source at the bottom. When she did a large-scale study of local resilience forums during COVID-19, what was found is that power shifted from local decision makers up to national structures within the country, such as, like the COBRA meeting. And local responders perceived a lack of trust from the central government. And part of that was because they received announcements at the same time as the general public, and information was withheld to prevent it being leaked. So this left hospitals and their local authorities feeling like they were constantly playing catch up. And so this sort of command and control structure that existed here in England really was thought to be inefficient and didn't capitalize on the greater situational awareness that these local authorities actually have. Now, this story continues, and I will tell you that something called the resilience framework, which is essentially the key learnings that have come out of the pandemic response, is going to be coming out sometime soon, potentially before Christmas. But it's really about how the government is looking at funding mechanisms for local resilience forums and how it can be strengthened. The governance around LRFs can be strengthened. And as well as hoping to have better alignment with the NHS, the integrated care systems that they have developed, the ICBs. And so, yeah, I think this story continues, but it is an interesting way of having national emergency preparedness and having health integrated. I'd like to move along rapidly here to slightly changing the subject. So we've talked about COVID-19, the types of elements, the activities that we need to prepare, some concerns. But I think that now that we're moving beyond the pandemic, we need to be concerned with additional hazards which face our health systems. And my specific focus is on those extreme weather events. And I would say that even more so, my focus specifically is on the extreme heat events, which many of you have probably felt if you've lived here in England for the last couple of years. And I am not a climate scientist, but I will just quickly describe this picture, this image, that as we have increasing CO2 levels, and this is leading to rising temperatures, we are seeing more extreme weather and rising sea levels. And what we know from that is that extreme heat is causing heat-related illness, death, and weather is leading to more fatalities as well as things like mental health impacts. So it is a cycle. So global healthcare systems, I feel like we're just at the cusp of dealing with such events, and we lack the historical experience and how to respond to it. And it's very complex because we may have to respond to multiple different types of disasters simultaneously. And this will require leadership focus, forecasting, really advanced hazard planning. And we know that the vulnerable populations involved, what is really terrible is that they are more likely to be impacted by a changing climate and the types of hazards that are present by that. Climate change is, for me as a health management researcher, it's it seems to be a well-established field academically. And from what I can gather from the limited amount that I've spent in this world is that mitigation and adaptation seem to be the key terminology they are using. And really what I believe is meant by mitigation is that's sustainability. How sustainable are organizations, and are they able to decrease CO2 levels, for example? So we think of the NHS net zero plan. Whereas adaptation is more likened to the emergency management response. How are we actually responding to the hazards? What are we putting in place to deal with them and to minimize risk? So it's just important to be aware of kind of the terminology here as we kind of begin to talk about weather. So there's obviously the Intergovernmental Panel on Climate Change, and there's a wealth of information there. And really, I just draw on this to talk about the impacts on health and well-being in relation to heat. Today, I'm really only focused on Europe and North America, but we see that what this shows us, if we look in this central column here, is there are increasing adverse effects to human systems resulting from heat. And they are at a medium level in Europe and high or very high described in North America in terms of their attribution. Now, when we talk about heat, what I mean is, and I believe in the UK it's described as when the mean temperature is above 20 degrees Celsius. But we also know in the UK last summer, sometimes it was as high as 40 degrees. So what is the actual impact of this on a healthcare system? Well, I'd like to use an example of British Columbia, Canada. The last 2 summers, they've experienced extreme heat events, and as a result had huge wildfires. So just in this last summer alone, 8,700 square kilometers were burned. That's approximately 4% of the UK's landmass, to give you an idea of context. There was also simultaneously extensive flooding. So these are massive challenges facing the healthcare system in British Columbia, known as interior health. And I should say that some of this research, great research, has been done by Jeffrey Totchkin, my PhD student. And so this is just, it was a very difficult year for the healthcare system in British Columbia. It was layered not only with COVID-19 pandemic, but events were more severe, more frequent, and costly than any other year previously. And as well, we're talking about an area with isolated communities. There's a lot of lakes, rivers, mountainous terrain, difficult terrain that necessitated not only healthcare facility evacuations, we had healthcare staff under evacuation orders, but just this unpredictable nature of wildfires. It was a great test to the healthcare system, and we saw, the system saw over 2,000 staff displaced, 181 evacuation orders, 8 private facilities evacuated. So you think about the scope of the scale required to manage a process like this, and I would remind you of what I described earlier, the incident management systems. You need extremely sophisticated incident management systems which can, bring in forecasting, bring in daily updates, and essentially have a nerve center for how you could run something like this, while also simultaneously keeping, your capacity to provide healthcare services running. Now, if we think about emergency management in this cyclical fashion, wildfires have a start and hopefully they have an end. And in this situation, they had an end. And when things like this end, there's an opportunity to do after-action reviews. And so just as an idea of some lessons learned, there was a health authority relocation plan developed. Creation, so I would describe these as kind of the mitigation techniques. Creation of a heat alert response system, to basically help build surveillance. And then a process for advising community health clients, both home and mental health, because if they needed to be evacuated, and how alerts and orders like that would actually work for their area. As well as, I talked about multi-agency training and working together. Well, in this case, health needs to work with the BC Wildfire Service to ensure their response, involvement in their response, and allow for better situational awareness. So that's a case of British Columbia. Now, if we come back to the United Kingdom, it's been hot here. It's been hot the last couple of summers, and it wasn't just me, because I actually found out that I think that this was perhaps one of the hottest summers on record. Like stretching back to since records began in the 1800s. Or 1888, I think the year is. But there was 5 hot spell periods last summer. And what that resulted in is there was more than 3,000 additional deaths attributed to heat above the 5-year average. And 2/3 of these deaths were actually women and older people. So the more, what they were, so there's people that are adversely affected. And so, but my question is, how do heat events like this actually impact upon the health organization? Because there is obviously well-established connections. Before you joined, we were talking about whether it's going to start snowing this week, and there is well-established connections between, cold temperatures and hospital pressures. And in England, this is typically known as winter pressures. But what about the actual heat events? What sort of impact might they have on healthcare organizations that we need to prepare for? So, drawing on some really interesting modeling work, which was done by Israelson et al. 2022. So generically speaking, hospital admissions during mild periods are typically lower. Okay, that makes sense in comparison to winter. And it's known that the optimal daily mean temperature for risk of hospital admission is around 16 degrees Celsius. But as the degrees rise, there's a rapid increase in the risk of patients being admitted to the hospital. So what these individuals had done, and this is a study published in Meteorological Applications, is they built a temperature admission risk model using the Royal Berkshire Foundation Trust. Now, the big limitation here is that this is based on one region of the country using one NHS hospital's data. So that is a limitation, but I think the findings are quite interesting and important. The pressure on the local healthcare system that they wanted to look at is how that might change in 50 years. So talking about 2050 as a result of climate change, looking at how the local temperatures are projected to increase with the risk factors of the current hospital admissions to understand how that scenario might change over time. And so as an emergency planner, when I saw this data, and specifically looking at the lower bottom left quadrant in green there. Now, not to be alarmist, this displays the change in the number of temperature-dependent beds. So we're just talking about temperature beds, not the other seasonal beds. But what this shows us is that the mean number of heat beds, which is this orange line here, this represents 2050. The black line represents today. So if we look at 2050 in this lower left corner, this tells us that the mean number of heat beds required for patients is actually similar to the number of beds required during the winter today. So that is quite concerning from a surge capacity planning point of view, from a staffing point of view. So this does report a peak in July and August. However, these, although there are limitations to this data, this is kind of I would consider it a call for action, and it's a starting point that we need to be considering as emergency planners and researchers. Now, this final graph, so previously I showed you changes in the number of temperature-dependent beds. This figure now presents the mean number of occupied beds in each month, and also includes it's more normalized and has the seasonal adjustments. However, what it shows us is there's still a new peak in 2050 in both July and August, and overall there is an equalizing of the admissions throughout the year, which means that might be useful from a staff planning perspective, but it can be quite difficult because it means hospitals are going to be under more pressure as time goes on. And listening to experts in climate talk about temperatures, it seems like temperatures are even going to get a lot worse after 2050. So this needs to be considered. So if you're still with me, if you're hanging in there, let's talk about some future research and next steps that I think are important. So to show you a theoretical model, if you remember at the start of the presentation, I showed you that traditional emergency management is thought of as a cycle. It is a cyclical process where we switch to a mode of responding, and then we proceed through, we have responding, we have recovery, we have mitigation. But there is a concept known as adaptive capacity. And it's really about our capability as an organization to bounce back to a state of normalcy after an extreme event, but also our ability to absorb disruptions during the event and reorganize throughout the disaster itself to retain our essential functions and structure. So an increasing adaptive response, which is what this Zhang et al. Study found, is linked to increased exposure to emergencies. So essentially, the more emergencies that you are exposed to, it essentially changes the mindset of the emergency planners to move towards this more adaptive model. And I think this is important because it's about adaptive learning. So rather than just learning from an after action perspective in a very discrete way, we are attempting to be adaptive during prolonged durations of emergencies or even concurrent emergencies that are occurring. So from a theoretical perspective, I think this is a really interesting model to consider when we are viewing data related to health emergency preparedness. And finally, some future research is, building on what I declared earlier about this sort of competency gap in healthcare leadership. We need to examine that. Emergency managers need a place at the boardroom table. They need to be an integrated part of how we deliver healthcare, given increasing risks in today's world. Adaptive learning should become more important as we are faced with prolonged and concurrent emergencies. And we need more, I've been very Western high income focused today, and I've started branching out into the low middle income type countries and their data on their health systems, and there is so many gaps. And I feel like there's so much cross learning that could occur. So I'm really looking forward to exploring how other health systems around the world are responding to similar events. And, about heat, I think that hospitals there's very much this idea of a winter pressures mindset, and we need to start thinking more broadly also to include, heat-related pressures on the health system and how we can respond to that. So I will wrap up on that. Thank you so much for your time, for those of you who stuck around, and I look forward to answering any questions you might have, or feel free to reach out to me later. Thank you very much.
Okay, thanks for that, John. We do have a couple of questions that have come in. Firstly, from Caroline de Bruin, I know that name well. Caroline says, I'm a librarian with the UK Health Security Agency and often run searches on this topic. Can John recommend a comprehensive glossary of emergency preparedness terms that I can refer to when constructing my search strategies, please? Currently, I'm referring to the hazard information profiles from the World Health Organization for extreme events terms, but do you know of any other kind of glossaries or taxonomies related to emergency preparedness?
That's a great question, and one I'd be happy to have further conversations around. I'm just thinking off the top of my head, just like you, we're usually left to build these searches on our own, and they're often very context specific. I know that the World Health Organization has a model for talking about health systems that might be helpful, but I would say, some of the phrases we've talked about today, emergency response, preparedness, and so on. So yeah, I'm not aware of an overarching framework, and you can see that's been one of the challenges of my own work, as I said, that there was no defined or validated way to assess preparedness in a hospital, so we essentially developed our own tool. But yeah, I'd be happy to communicate with you more about that. I've recently applied for funding to do something like you're asking, and so we will be looking to develop those search terms ourselves. So I'd be happy to hear from you.
Okay, thanks for that, John. Another question from, I should, just before we move on, Caroline's put a link in the chat, so I'll just draw everybody's attention to that, about a couple of monthly briefings that she's involved in preparing. But the other question we've had is from Katie, who asks, has any research taken place on how primary healthcare systems respond to emergencies? That's a really interesting question, because I think in the UK, the sort of general practice response to COVID initially was quite heavily criticised, with the sense of, well, they've just shut down.
Yeah, so that was Katie, right?
Yep.
So I think that's a very interesting question. I'm actually a part of a project in Canada, and I would say what's been given primacy in that field is probably the shift to virtual care, right? It's the shift to overnight switching from face-to-face appointments to virtual care delivery, and now I think governments and funders are looking at how that can be scaled up to be something that is actually sustainable, that is low patient safety risk. So I would say that research is ongoing, but if you were interested, I would look around the shift to virtual care, sometimes called telehealth, telecare, but look specifically within the context of pandemic preparedness, because, like, let's be honest, that, you know, when COVID hit, it was an overnight shift, and it was a dramatic change. But primary care is typically, depends on the country, they may not even have a place at the table in the emergency operations center unless you have a really well integrated healthcare system. So I think that's an interesting question. I wish I could shed more light.
Okay, thanks for that, John. I'm just going to have a quick scroll through the chat to make sure whether there's any more questions, but I don't think so. Okay, in that case, I'll draw it to a close. But thanks everyone for joining us today. Some really interesting questions and a really great presentation from John. So I guess all that's left to say is have a lovely Christmas, everyone, if you're celebrating, or just a break from work if you're at least getting that. And we will see you in January with Katie Biggs and that presentation about inclusive clinical trials. Thanks, everyone.
Thanks, guys. And Carolyn, be happy to hear from you. In fact, any of you, if you want to link up, just drop me an email. I'll be happy to chat. Thank you.